Welcome to Sit and Stay, the podcast that breaks down the challenges of starting and maintaining a mental health practice into digestible chapters. Sit and Stay is presented by RipsyTech, an electronic health record company committed to addressing the mental health crisis in the United States.
Tom, good to see you.
Parker, good morning, or I guess good early afternoon where you're at.
It is the early afternoon over here on the East Coast.
Very good, very good. How's the weather today?
Great question. It's been a little on and off. So today it's looking mildly nice, if that's the right way of putting it. Slightly cloudy, getting a little bit warmer. So it's that time where you have to wear your what I call transition clothes.
Gotcha.
Between cold and warm. You don't know, is it going to be one of those days where it's cold at the beginning and hot at the end, and you got to prepare for that?
Yeah. That's a similar day here in Berkeley. It's a strange phenomena, but when it's like 65 and sunny, it actually feels pretty warm here. But you get these cloudy days, and sometimes the clouds burn off and sometimes they don't, but it is very transitional weather here as well. And today we're devoting the podcast to weather discussions, correct?
Yeah. How can weather affect your practice? No, that is not today's topic, though. I would be curious to see if anybody has any thoughts on whether there might be something there. But no, in fact, we are actually talking about insurance companies, specifically what it means to be in-network versus out-of-network, which is a pretty big thing. And also, for me, as somebody who never worked in healthcare before, for the first time, 8 years ago, learning about this whole in-network, out-of-network thing was very eye-opening. I had no idea really what any of that meant, especially, I guess as a 22-year-old, you just assume whatever insurance you have, just go see somebody, you'll be good, right? But yeah, no, it's a very complex topic, especially for providers who are starting out their own practice for the first time, as I've come to find out.
Yeah, it is indeed. And I think as a mental health clinician, it is one of these few fields in medicine where you can decide to not accept insurances and still build a thriving practice and get patients. And there are not very many fields in medicine where this is actually possible. I think most people know that plastic surgery is something that insurance doesn't cover, and that is a part of medicine. Well, some insurance covers some plastic surgery, but in general, cosmetic optional procedures, those are medical procedures not covered by insurance. And that, other than plastic surgery and specifically in medicine, psychiatry, it is hard to think of too many other fields where you wind up being out of network or not being able to use insurance to cover services. There is this growth of concierge medicine practices where people pay a subscription fee, usually per month, and this helps get you better access to a team of primary care providers or pediatricians or mental health professionals. And that's been growing because of frustration with, again, people being able to find good care with their insurance and mental health. But other than that, it's very few places for medical care that you can't use insurance.
Yeah, I'm recently just learning about this concierge service thing. So you're saying that is something that does not go through your insurance at all. It's really just a monthly fee that's completely unrelated to the insurance company. It's just between you and the provider?
Yep, that's correct. And a lot of providers, especially primary care providers, are embracing this model because when you're churning through 4 or 5 visits per hour in a primary care clinic, that's a lot of patients. You don't get much time with your patients, and it can be very draining and increase burnout. So some people have elected, if you do this concierge practice, you can get your panel down to maybe 40 or 50 patients from hundreds. It gives you a lot more time to spend with your patients, and can also get you the same income as a practitioner. But it is something that is not covered by insurance. It is, if you're the customer, it essentially buys you easy access to your healthcare providers. And for people who desire that and can afford to pay for that, those practices are rising throughout the country.
Interesting. Okay. So, well, that, as you described it, arose out of the complication for a provider deciding to be in network versus out of network. And I understand that largely comes down to reimbursement rates from the insurance companies. Is that correct?
Yeah. So on a basic level, when you first start, if you're going to hang up your shingle and start your practice and see patients next week, you're just not going to have time to procure any insurance contracts, even if you want to. So all those patients you start seeing, they're going to be considered out-of-network patients. And what that means is if they have an insurance plan that's HMO only, then those families are not going to get any reimbursement from going to see you, and they're going to have to pay your full charge master charge. Some people do have insurance plans that have out-of-network coverage, but this can be very misleading for people. First of all, there tends to be very high deductibles before any coverage kicks in for out-of-network services. But the biggest confusion point is, if you charge $500 an hour for services, and if someone has a plan and they see, we have out-of-network coverage and it pays 70% of the charge, it's not actually going to pay that 70% of your $500 charge. What it's going to pay is 70% of what the insurance company says would be a reasonable charge for that visit, which is often $150 is what they might say you're entitled to. So you get 70% of $150, that's $105, but the visit is $500, and so you're still paying a big chunk out of pocket. So we always want to be, and you'll see most cash practices will give a super bill that you can submit for out of network, but it's very important that the patients know it's not going to cover 70% of the full cost or 50% of the full cost of services. It's going to be 50% of, quote, usual and customary fees, which to the best of my ability after all these years is sort of a random number set by each insurance company as to what they'll reimburse. And then this is in contrast to if you're in network, you can go in and your plan may have just a $20 copay. It may have a 10% coinsurance, but as a patient, you're going to pay the same charge each visit if it's a copay amount, or you're going to know, if it's a coinsurance, the charge that you might pay a little different amount each visit, but it still tends to be a low cost if you're able to be in network with your insurance.
So in that scenario where you go to see a cash practice, does that provider have to submit to your insurance company? Or, I see a lot of cash practices over in the state that I live in, and, are they obligated to take your insurance information, or are they allowed to just kind of see you take your money out of pocket and pretty much never talk to your insurance company?
Yeah, so there's the legal requirement is that clinicians have to provide a super bill, which contains the information needed for a patient to submit the visit to the insurance company on their own to see if they get any reimbursement. The super bill contains your license information, a diagnosis code, what was the procedure that was done, and everything that a patient needs to try to get reimbursement. But as a practitioner, you are not under any legal obligation to submit the insurance claims on behalf of your patients. I do actually think that even if you're going to be a cash practice, it can be a nice service to offer to your patients to do the claim submission for them, even if you're out of network. And that's what I've always done. There's an advantage as to a provider that if someone does have a insurance plan that pays some reasonable amount of money, that check can, again, it depends, but usually the check will come right to you and you can just bill the patient the difference. It has gotten easier for patients to submit super bills. With the rise of the internet, you used to have to sort of mail them in and wait a long time. Now, you can log into your own Anthem or Aetna or Cigna account and submit the super bill information yourself, and that speeds up the reimbursement process. But as the practitioner, your only obligation is to give people a super bill to submit to insurance on their own.
Gotcha. And so, okay, so and then to your point, it's good practice to submit it on their behalf anyway, but then also, I imagine if I was doing it and I was providing somebody with a super bill, I would try to provide some amount of instructions on, like, here is how you would get this to your insurance company.
Yeah. And I think, it's whatever help you can provide your patients to help navigate the insurance system, especially if you're not going to accept insurances, I think is a nice perk. I think it can actually be a differentiator as a practice that even if you don't accept insurance, tell your patients that, yeah, we don't accept insurance, but we'll at least go ahead and do the submission for you if you have some insurance coverage. And we have a lot of clients of RipsyTech that go ahead and do the claim submission and pay the 12 cents a claim to do that for their patients. And it at least takes the hassle of patients submitting the super bills on their own, which most practices don't do.
Okay, so as for the questions that I have written down, I actually kind of want to change up the order a little bit just based on what we're already talking about. So on this topic of being out of network, are there any advantages to being out of network or challenges of being out of network? We've talked about some already, I think, but are there any others that stand out?
Yeah, and I think, there's a reason why half of all mental health professionals don't accept insurance. And I think you touched on one big one, which was, and I did a little with the usual and customary, but one was insurance companies just not offering reasonable reimbursement for services. But I would also say right up there with that is the hassle and frustration of actually dealing with insurance companies to get whatever that reimbursement is. And I think I've even talked about it in some of the earlier episodes. When claims get denied, and sometimes denied for no reason, it can be hours of your time to get those issues resolved. And when I've talked to colleagues over the years, it is actually maybe less about the reimbursement and more about the hassle of trying to deal with the insurance companies to get your payment. That is a bigger barrier for people to accept insurance. Those are very valid reasons, and especially if you're a solo practice or small practice, you just may not have the bandwidth to deal with insurance companies.
Yeah, I mean, time is one of our most valuable commodities in life, and especially if it's. I would say of the things that I would like to do with my time, talking to an insurance company might be the bottom of the list.
Right. Yeah, and the disadvantage of not being in network for a provider is it can be a slower ramp up to fill your schedule.
Right.
You may have more problems with collecting payments from your patients with what they owe. Yeah, and then there's just also, and this is an individual feeling for everyone. I've maybe mentioned that, you know, it just can feel wrong to be charging people high amounts of money for what in a perfect world people could use their insurance for coverage. This has been propagated for years in the mental health industry. And there's many factors that have resulted in this issue. But if we had more practitioners willing to fight for appropriate reimbursement rates from insurance companies, and as technology gets better, it is getting a little bit easier to deal with insurance companies to get your payments. I think that would be better for the industry as a whole, but very complicated market and economic factors that go into play there.
Right. So then on the flip side of things, being in network, what are the financial operational implications when somebody decides that they want to be in network with the insurance company?
Yeah. And so since 2007, I've been working with insurance companies. And the interesting thing is, depending on where you live and the status of the state and insurance coverage, there are some states, Minnesota, Illinois, where almost everyone expects to be using their insurance for mental health services. And in those states, where there's enough providers that accept insurance, if you just try to start a cash practice, it's going to be very difficult to fill. And, as soon as patients find someone who accepts their insurance, they're going to bolt to be able to just pay their copay. I've found over the years that usually you can find some insurance companies that do actually offer fair reimbursement. And if you can even find one insurance company that offers fair reimbursement, then you're off to a great start, and it gives you a leg up in negotiations with other insurance companies. And the second that you're in network with an insurance company, the patient referral to your clinic is going to expand drastically, and you'll have much more selection of patients to accept into your practice and be able to grow your practice faster. And especially if you want to bring on other providers, grow your business, being in network is going to make that a much easier task than staying out of network for your patients.
So the next question I have, I think you're already really touching on it, was, being in network, being out of network, how is that going to affect, the patient's ability to access services and afford services? Is there any, you've kind of touched on that quite a bit already. Is there anything that you'd like to add to that?
Yeah, I mean, there's been some great legal advances over the last 15 years, whereas when I started seeing patients in 2007, you used to have to do a prior authorization form if you were going to do therapy visits with them. Every 3 to 6 months, someone might call you to check about utilization of services. But since parity laws have taken effect, a lot of the prior authorization hassles to working with insurance companies are just gone. And we actually have some insurance companies where we, as psychiatrists, see patients 2 or even 3 times a week, and we don't have to worry about any prior authorization with the insurance company. Every visit is covered, and that's, if you can imagine a patient coming in a couple times a week and just paying their $20 copay for very sick patients or people who need extra care, the cost would be prohibitive if they're paying several $100s per visit versus that $20 copay. And it gives you, it gives you a nice incentive for working with your patients to be, subconscious or not, when you have a full cash practice and you're working to get full, your income depends on having those slots filled. And if you don't have a lot of people waiting to be seen or a wait list, there can be a little bit of a subconscious feeling of, maybe not wanting your patients to get better. That's a controversial statement maybe to say, but when you have a large wait list or you take insurance, I do think that you're not worried if a patient gets better and you can start reducing the frequency you see them, or you've pushed for a cure, of which a lot of mental illness is curable, and especially with kids that we work with. So I think that's another implication of being in network versus out of network. I'd even say that in a state like California, we have a lot of different insurance providers. There's got to be 20 plus
Right.
insurances here, versus in other states there's maybe only 2 or 3. And if you're able to just get in network with even one insurance, it's a nice message to your patients that are out of network, which is, hey, well, look, we got reasonable rates from insurance company X. On your next open enrollment, or before that, you can go to your HR department and say, hey, we want this insurance to be offered to us because we can go to this clinic in network then. And so even if it's a nice talking point for a patient that says, well, how come you don't accept my insurance? You can be clear that they offer very low reimbursement for our time, but we are in network with this other insurance company that pays reasonably. So if you can switch to them, then you'll be in network for your services with us. And it's just a nice, I encourage everyone who's starting a practice to at least find out who the major insurers are in your area and reach out to them and try to negotiate. And you might be surprised at what happens.
Awesome. I have a little bit of a curveball question that kind of came up as you were talking. For me, not as a provider, but somebody who could be a patient. Speaking from my personal experience, there's almost this sense of, if I see that somebody is in network, but then I'm looking around for the right fit, and I see somebody is out of network, there may be this subconscious bias to think, oh, the person who's out of network must be really good at their job. And that's why the insurance doesn't cover them, because they want to reimburse really highly for their services. They think their services are so good. Have you ever kind of come across people thinking that, or any providers who maybe think that way, or say, hey, I want to be out of network because people will. It's a really good way to sell myself. Or I don't know. I'm just kind of thinking out loud.
Yeah, no, it's a good question, and there is maybe some truth to what you're saying. I'd say, in general, probably for the most part, people who go out of network have done it just because they don't want to deal with the insurance company or for the reimbursement rates. That being said, you do need maybe a little extra business savvy or charisma to build up an out-of-network practice on your own. You might need to do a little more marketing. You might need to embrace social media. And there is this other skill set that you might need if you're choosing to do an out-of-network practice. And not everyone is maybe suited to doing some of those extra marketing steps that are needed to do that. It is also true that if you've garnished a reputation as being a top clinician in your area, that it might be impossible for the insurance companies to actually reimburse what you're worth. And that becomes a barrier to you accepting the insurances as well. I would say that if you're a physician or a prescriber, you often have better luck with negotiating with insurance companies. I think insurance companies treat psychologists and therapists much worse and tend to really undervalue the benefit of therapy and being a good therapist and a good psychologist. And so there tends to be a much harder path for some therapists and psychologists, but I do know lots that have managed to get reasonable reimbursement rates. A lot of therapists and psychologists that have pulled that off. But I think in general, you will see that some of the most skilled therapists and psychologists tend to be out of network because they bring that charisma and rapport skills that are important factors in the healing process. So if you're
right,
you've already got some of that if you've entered this field. And I do think it is a little harder negotiation battle as a non-prescriber with insurance companies.
right. So it's not just charisma that you're applying to marketing your practice, but also to the quality of the care that you're providing to your patients.
Yeah, there's some well-documented research that if you don't have good rapport with your patient by the fourth session, regardless of how skilled you are at different evidence-based techniques, likely you're not going to have a successful treatment course. So that skill that comes with building rapport and your patients really liking you is a good predictor of treatment outcome, separate from your skill at using different evidence-based techniques for treating your patients.
Interesting. Yeah, no, that's a really good point. I'm glad you brought that up. So, kind of coming close to the end here, are there any other long-term implications for a practice's growth and its sustainability based on whether it's choosing to go in-network versus out-of-network?
Yeah, good question. And I think this really boils down to if you're not in a rush to fill your practice and you're really going to be a solo practice or maybe just have a couple providers, you can definitely fill your practice over time as an out-of-network clinic. If, however, you do have a vision of operating a larger clinic, having more employees, bringing in colleagues, it gets very difficult to do that without having some heavy flow of patients. And the easiest way to make that happen is through insurance contracts. I will say, one other strategy, if you don't want to fully go in network with insurance companies, is that you can sign up to become an EAP, an employee assistance provider. And a lot of companies will give people like 5 visits with a mental health professional complimentary. So if you sign up as an EAP provider, you agree to accept some reimbursement for those sessions. That's a great way to build that rapport. And then if those patients really like you and want to continue, they would be out of network, but it gets a lot of people in the door for a few sessions and is a good strategy for building your practice. And less of you can agree to take a lower rate reimbursement for those initial sessions if you know that these patients are going to convert into out-of-network patients and you're going to get paid higher after the first few sessions.
Interesting. Yeah, no, I had no idea about that. Thank you for sharing. So I'm sure there is so much more that we could talk about on this topic, but we do want to wrap up soon. So I think now would be a great time to transition into a mental health business moment of the week. Do you have anything? What do you have for us? Yeah,
and trying to keep it specific to our discussion of in-network versus out-of-network. So our nonprofit clinic is currently in network with 3 insurances, and we have a streamlined path for getting single case agreements, which we could maybe talk about on our next podcast with another insurance. But we've been working hard with one insurer that is a very large insurer in the state of California, and started reaching out to this insurer last November. And I actually have some contacts within this insurance network. But despite this, I've been sending emails, leaving voice messages kind of once a month. I was really happy when exactly about 5 weeks ago, someone who I responded and copied someone else and said, here's the people that handle clinics that start with these letters and they'll get you moving forward. And then just today I was looking at how sent a nice long email 5 weeks ago and thanks for reaching out and so excited to get started on the negotiation and process. And it has just been radio silence. So right now we're pushing 5-6 months since we started. We had this hopeful moment a month ago, and then just stuck here with no response to emails and phone calls. And, I don't think it's maybe necessarily, we have patients with this insurance who want to use it and come see us, but I think it's be prepared for a lack of urgency on the time of, a lack of urgency from insurance companies when you're trying to go in network. You're the one fielding the phone calls from the desperate patients, not the insurance company. And
right.
That's frustrating, of course.
Right. All right. Well, yeah, I think that's that's that is a mental health business moment of the week, right? I guess, for lack of a better way of putting it. Well, I think this has been a great episode. I think we'll continue the insurance discussion going into next week because there's still so much more that we can talk about on this particular topic. I had one thing in mind for what we would talk about next week in regards to insurance, and now I've got even more ideas of things that we could talk about. So this has been great, and I think let's go ahead and wrap it up here.
Very good. Thanks, Parker. Yeah, good topic.
Yeah, thanks, Tom. I'll catch you next week then.
Sounds good. Bye.
All right. Bye.
Thank you for tuning in to this week's episode of the Sit and Stay podcast. Until we meet again, we invite you to sit and stay with the ideas and stories shared today. Dive deeper into how RipsyTech can support your practice by visiting us at RipsyTech.com.